So I would like to thank the organizer for this very interesting subject. We spend a day on it. So the recent ESC guidelines state that the potential role of transcatheter tricuspid valve treatment in high-risk patients need to be determined. That means that there is no guidelines. In summary, tricuspid is the forgotten valve. It's frequent, 1.6 billion per in the USA, underestimated, clinically silent until late stage, poor prognosis. In fact, we are guilty because we do not look at the tricuspid regurgitation. Mainly secondary regurgitation. We forgot the primary regurgitation. It is due to annulus and right ventricular remodeling. It is more after left annular, left or mitral or aortic valve disease. And diagnosis, imaging is absolutely key in order to treat. So, diagnosis will be able to look at the severity and the variability. Echography is absolutely key for the severity of regurgitation. Evaluation of right ventricular function, echo 3D is key, and it will exclude the patients. It has an excellent temporal resolution. NMR is excellent for evaluation severity of regurgitation, evaluation again of right ventricular function. Do not operate patient too late. And looking at reversibility. CT also is very important for the evaluation of RV, anatomy, and excellent spatial resolution. So in this slide, we can see on the top from A to D, in fact, the transthoracic, looking on the left, the posterior or anterior leaflet, and then only the anterior leaflet, and then on 4D, the posterior and septal leaflets, and not forgetting the subcostal, looking at the posterior and the septal leaflets. And then you have the transesophageal echo, which will be also very useful to look at all the details of the valve. So these data from Han, I recommend you to read this paper, looking at the evaluation of the regurgitation vena contracta with considered as mild, moderate, severe, massive, torrential. Torrential, it means that when you pick the femoral vein, it is pulsatile. The area by PISA is also very important, giving also the same criteria, and then by 3D you can also look at the vena contracta area. So NMR, you can see here very clearly the different possibilities of anatomy, looking at 4 chambers on the top, 2 chambers in the middle, or the right ventricular outflow tract on the right. It's also very good to measure the regurgitation volume, and it is not written on the slide, but also the ejection fraction of the right ventricle, which is also a very important prognostic parameter. The CT scan is also useful in terms of looking at the severity. For example, here in this slide, you can see the flow coming from the superior vena cava, going to the right atrium, and then going directly to the inferior vena cava, and on the right to the hepatic vein. It also gives wonderful possibilities of measurements, which is very important for sizing. So going to the treatment. In fact, theoretically, you have 4 ways of treatment. The annuloplasty with cardioband, 3-line, 3-inch, millipede, and tripta. And then the leaflet coaptation with MitraClip, Pascal, and Forma. And then the CAVI. CAVI means that you will put a valve in the inferior vena cava and superior vena cava with trach valve and sapien. And then the TTVI, the TAVI for the tricuspid, with 4 possibilities. To make short a long story, annuloplasty is a major treatment with cardioband and 3-line. And you have also the leaflet coaptation with MitraClip, and then there is no data on CAVI and no data on valve implantation. So TTVI is challenging because large tricuspid annulus slice, it is non-planar, it is fragile annular tissue, and there is no calcified annulus in second tricuspid regurgitation. Angulation relation to the superior inferior vena cava make it tricky too. And then the right ventricular wall is very thin. The proximity of AV node and right high parantal branch is another problem. Proximity to the right coronary artery to annulus and risk of coronary injury, risk of occlusion of the sinus, vena cava, or outflow tract. The slow flow in right ventricle and patient with pacemaker or defibrillator leads, which makes it, in fact, a contraindication. So this slide from René Scabo, it's a very good review showing the summary of the data on treatment, theoretical treatment. Coaptation device with on the top left, and you have the heterotoptic valve implantation, which does not exist, and then the annuloplasty device, in which we will come back soon, and then the coaptation device. So on the left, you have the mitra clip or triclip, which is where we have the most of data. You have the cardiobound, in which we have some data, which is an annuloplasty system, and then navigate valve, which is totally virtual. The mitraline or trailing, in fact, it is a device which will insert, it is mimicking surgery. In fact, you will reduce the annula and then reduce the annular area, as you can see on the bottom with the echo. With 3D echo, just to mention that echo will also be very, very important during the procedure, guiding the system. So you see on the top, the catheter putting a first plate and then a second plate on C, and then on E, you hold the system so you narrow the annulus, and then this is it. So showing again the echo with the vena contracta measurements, showing that in fact you can clearly, objectively show whether you did something or not in terms of reduction. And those data showing that in fact you reduce NIHA and then the MHFAQ criteria, and then the 6 meter walk training. So it's a small 28 patients. You can see the NIHA on the top, the 6-minute distance, and then on the D you have the edema grade, which helps you to see that there is an improvement in this technique. So the 3-inch system, I go very fast because I don't really believe in it. It's a system composed with a corkscrew anchor, a self-expanding stent, and then the diaphragm connecting them, and then it will hold the annulus, trying to restrain decrease the annulus size. So the triclip, and then I will go a little later on that, it is like the mitra clip, in fact. So the objective was to evaluate the safety and performance of the triclip in patients with symptomatic tricuspid regurgitation. It was a single-arm multi-center study in 21 sites in the US and Europe. And the effectiveness was judged on TR reduction at least 1 grade at 30 days procedure. So safety was a composite of major events at 6 months. So you can see the patients are old. The NYHA is around 75%. So the whole score is high. And the PA pressure is 39, and BNP is also elevated. So the procedural data was a success. Just note the device time 75 minutes and the hold time around 3 hours. Number of clips implanted in the per subject, it is around 2 clips. And then the leaflets attachment location, which is interesting, it is basically the anterior septal clip, which is the most frequently positioned. And then you see the tier grade on the right, which is very interesting because clearly there is a reduction in the torrential from 35 to 5%, and then going from known to mild from 6 to almost 60%. So the area has decreased, not exactly by 2, but almost. The regurgitant volume is interesting. The regurgitation jet area also has decreased. The vena contracta go from 1.73 to 0.99. And the events are very favorable because there is no death at 30 days. There is one onset renal failure, and if I can have a little minute more, please. The tricuspid valve being gradient greater than 5 minutes mercury is 4. So those 30 days data demonstrate no risk for death, stroke, myocardial infarction, endocarditis, or non-elective cardiovascular surgery. Therefore, there is no safety concern for this technique. The NIHA functional class go from 25 to 80% in terms of the 1 and 2 class. And so the trick effectively reduce the TR by at least 1 grade. Subject experience a significant improvement in quality of life and NYHA functional class. And the 3-minute study found age-to-age repair is a promising treatment, but we are in a small series again. So in conclusion, it is a forgotten disease by the clinicians. And we should do surgery on tricuspid when we do surgery for mitral disease. This is a clear lesson. TR imaging, echo is key before, during, and after procedure. NMR-CT also play their role in terms of finally be sure that we do not operate patient too late. The TR percutaneous treatment, there is no guidelines, few data, no valve replacement. And I would insist in the annulus stretching, and especially in the valve coaptation. This is the reason I gave you all those details with the tricklip in 3 minutes. We are waiting for more data and a longer follow-up, but this is a very, very interesting area. Thank you very much.